dear students. We should continue our lecture. And today the topic of the lecture will be hemostasis. I introduce the head of our department, Dr. Yemelyanov Dmitry Nikolaevich.
Okay, good afternoon, guys. So today we start talking about hematology, diseases of blood, and first lecture will be about bleeding disorders, So before talking about bleeding disorders, let's remember what does it mean hemostasis? What does it mean hemostasis? Hemostasis is a complex process dependent on interactions between the vessel wall, platelets, and coagulation, and fibrinolytic mechanisms. So we have three components of hemostasis. Now, what for we need hemostasis? You know, because actually in case of damage of vessels, water is liquid, and in case of leakage of blood, blood is liquid, and in case of leakage of blood, patient may die, and that's why we have special mechanism to prevent such leakage, to stop such leakage. In this case, we talk about hemostasis. So we have three components of hemostasis. This is vessel wall, this is platelets or thrombocytes, and coagulation and fibrinolysis. Vessel wall. The vessel wall is lined by endothelium, which in normal conditions preserve the circulation by preventing platelet adhesion and thrombosis formation. Injury to vessels cause reflex vasoconstriction, while endothelial damage results in loss of antithrombotic properties, activation of platelets, and coagulation and inhibition of fibrinolysis. Again, main idea that this is damage of vessel, start coagulation process, cause coagulation process. Platelets. Platelet adhesion to collagen is dependent on platelet membrane receptors. Following adhesion, platelets undergo a shape change from a disc to a sphere, spread along the subendothelium, and release the content of their cytoplasmic granules. So, what for we need platelets? You know that first primary stop of bleeding happened due to formation of so-called white thrombi. Why white thrombi? Because it's made from platelets, from white cells. And actually, in case of vessels damage, first what happened? That thrombocytes close this damage with their own bodies. They just plug actually this damage with their own bodies by formation of actually white thrombi. And of course, they also release some components, some granules, some substances which force coagulation. Coagulation cascade involves a series of enzymatic reactions leading to the conversion of soluble plasma fibrinogen to fibrin clot. So finally, stop of bleeding happened due to formation of so-called red thrombi. Why red thrombi? Because this is formation of three-dimensional net made from fibrin. Fibrin, this is very strong molecule, made from fibrinogen, which present normally in our blood. And in case of coagulation, these fibrinogen short molecules combine together, stick together, and they form fibrin, three-dimensional net. Why this thrombi becomes red? Because it traps a lot of erythrocytes, and that's why it has such a red color. Coagulation factors primarily synthesized in the liver, and that's why in case of liver disorders we also may expect some problems with coagulation. So this is complicated cascade of coagulation. You know, we have different so-called coagulation factors. And all coagulation factors, this is some kind of proteins, enzymes, and they change each other, formatting a few steps of coagulation. First step, when we have formation of thromboplastin, then prothrombin change to thrombin, and final stage, fibrinogen change to fibrin. So, if you have patient with bleeding disorder, what you should find out, first of all. First question, is there a generalized hemostatic defect? So what does it mean? Because hemorrhages may be local, may be generalized. And supportive evidence for this includes bleeding from multiple sites, spontaneous bleedings, excessive bleedings after injury. So again, most of bleeding disorders, they have generalized characteristic. And that's why first you should find is it generalized or localized. Again, if we have a patient with bleeding from multiple sites, spontaneous bleeding, excessive bleeding after injury, okay, this is generalized hemostatic defect. Second question, is the defect inherited or acquired? A family history of bleeding disorders should be thought. Severe inherited defects usually become apparent in infancy, while mild inherited defects may only come to attention late in life. For example, with excessive bleeding after surgery, childbirth, dental extraction, or trauma. Some defects are revealed by routine coagulation screening, which are performed before surgical procedures. Next question, is the bleeding suggestive of a vascular platelet defect or coagulation defect? Again, I told you that we have three actually components of hemostasis: vessels, platelets, and coagulation. And actually, of course, we'd like to know where is defect in case of bleeding. This is vascular platelet defect or coagulation defect. Vascular platelet bleeding. Vascular platelet bleeding characterized by easy bruising, spontaneous bleedings from small vessels. Now, you know what is an easy bruising. Bruising, it's normal. When you beat, I don't know, your hand or your leg playing football, you may find bruising. But in case of easy bruising syndrome, even slight pressure may cause appearance of blue and black marks. In this case, we talk about easy bruising syndrome. No spontaneous bleeding from small vessels, from nose, also may from gums, also may tell about vascular platelet mechanism. There is often bleeding into the skin. The term purpura includes both petechia, which are small skin hemorrhages varying from pinpoint size to a few millimeters in diameter, and which don't blanch on pressure, and ecchymosis, which are large areas of bleeding into the skin. Bleeding also occurs from mucous membranes, especially the nose and mouth. Coagulation disorders. Coagulation disorders are typically associated with hemarthrosis. So this is accumulation of blood in joints, hemarthrosis, filling of joints cavity with blood. Muscle hematomas, bleeding after injury or surgery. There is often a short delay between the precipitating event and overt hemorrhage or hematoma formation. So it means that some trauma immediately causes formation of severe hematoma or severe hemorrhage. Which laboratory investigations we can do to confirm origin of the bleeding? Now, of course, first of all, blood count and film show the number and morphology of platelets or thrombocytes. And any blood disorder such as leukemia or lymphoma which may cause bleeding disorder. The normal range of platelets count is 150, 400, 10 times 9 per liter. What else we can do? Bleeding time. Now, bleeding time measures platelet plaque formation in vivo. It's determined by applying a sphygmomanometer cuff used to measure blood pressure normally to the arm and inflating it to 40 millimeters hydradral. Then 1 millimeter deep and 1 centimeter long incisions are made in the forearm with a template. Each wound is blotted every 30 seconds, and the time taken for bleeding to stop is recorded. Normally, it's between 3 to 10 minutes. Prolonged bleeding time are found in patients with platelet function defects, and there is a progressive prolongation with platelet counts less than 80, 10 times 9. The bleeding time should not be performed for a low platelet count. So, idea of bleeding time is very simple. Let's make small wound, and let's see how soon the bleeding stops. It may be forearm. Sometimes they use ears to make such small wound. And actually, remember please, that bleeding time, this is platelets. This is not coagulation, because I told you that first stop of bleeding happened due to aggregation of thrombocytes. And that's why bleeding time tell us about functioning of platelets, and number of platelets. Coagulation tests. Coagulation tests performed using blood collected into citrate, which neutralize calcium ions and prevent clotting. So what does it mean? To perform coagulation tests, we should take patient's blood. But you know, if you take patient's blood, it immediately should coagulate. To prevent coagulation, we use citrate, natrium citrate, because natrium citrate remove calcium from plasma, and without calcium, no coagulation. Calcium is one of coagulation factors. That's why we use citrate plasma to prevent clotting and to produce in the future coagulation tests, to perform coagulation tests. Which coagulation tests is usually done? Prothrombin time. Prothrombin time is measured by adding tissue thromboplastin in the form of animal brain extract or recombinant equivalent and calcium to the patient's plasma. The normal prothrombin time is 16-18 seconds, prolonged with abnormalities of factors 7, 10, 5, 2, 1, liver disease, or if patient is on warfarin. Warfarin, this is remedy which prevent coagulation. So, you know, idea of all coagulation tests. Remember I told you that coagulation, this is complicated cascade process. Cascade that one substances cause changes in other substances. And finally, it should reach actually fibrinogen and to force fibrinogen to form fibrin. And that's why if we have problems with coagulation, we should try to understand where is problem, which factor absent or which factor malfunctioning, how we can do this. We can do what? If you expect that we have problems with first stage of coagulation, when we have formation of thromboplastin. For example, in patient, no formation of thromboplastin. It's happened, for example, in patients with hemophilia, because in hemophilia, deficiency of 8 factor lead to inability to produce thromboplastin. So what we can do? Let's give patients plasma thromboplastin from outside, from animals or from other actually patients. And if we give thromboplastin and coagulation becomes normal, it means that we find the problem in this patient is formation of thromboplastin. For example, it may be again in patients with hemophilia, for example. So this is idea of all these coagulation tests. This is substitution, I may say, substitution of patient's own factors by factors from outside. And we see what have happened. If everything normalized, okay, we find out where is the problem. No activated partial thromboplastin time, APTT. So, performed by adding a surface activator such as kaolin, phospholipid, platelet substitute, and calcium to the patient plasma, and normal APTT 30-50 seconds. Again, APTT usually tells about coagulation generally, how it's happened. And if patient has some problems with coagulation, it's revealed by this APTT test. Thrombin time. Remember I told you about prothrombin time. And now thrombin time. This is another similar test, but in case of thrombin time, instead of thromboplastin, we add thrombin to the patient plasma. Normal thrombin time 12 seconds, prolonged with fibrinogen deficiency. So again, idea is following that thrombin should do what? Change fibrinogen to fibrin. And if we add thrombin and again we still have problems with coagulation, only one possible explanation. This is problem with fibrinogen, because we add everything already what patient needs for normal coagulation. Correction tests. Idea of correction tests. You know that we have 12 factors of coagulation, and we can add one factor by another and see what happened. And finally, we can see which factor we should add to cause normal coagulation. And if we find this, we can say, okay, this is deficiency of 8 factor, for example. Okay, next, vascular disorder. Okay, let's now talk about disorders. Before this, we talk about examination. Now let's talk about disorders. So actually, vascular disorders is not really hematology. This is not problems with blood. This is problems with vessels. And that's why in many cases, in most of cases, vascular disorders treated not by hematologists, but by rheumatologists, for example, by specialists actually in systemic disorders. What may happen with vessels? No, sometimes we may see congenital problems. No, for example, hereditary hemorrhagic telangiectasia, so-called Osler disease. This is genetically weak vessels in some parts of patient's body, which periodically cause bleeding. Acquired vascular disorders. For example, meningitis, meningococcal infections usually presented with some petechias in patient's blood. Why? Because this process causes damage of vessels and it causes some small bleeding. That's why in case if you expect meningitis, check patient's skin, because, for example, severe headache plus hemorrhages in the skin, petechial hemorrhages. No, this is very serious. It may be meningitis. Very common allergic disorders. Allergic disorders. This is phenoxyl-lane purpura. We'll talk about this later. Some remedies may cause damage of vessels. For example, steroids, like prednisolone, which we use widely to treat patients with bronchial asthma, with lupus erythematosus, with rheumatic arthritis, may cause damage of vessels, and in this case may cause bleeding. Others, for example, senile purpura, bleeding which happened in elder people, because in elder people everything becomes weak, including vessels. Okay, vascular disorders. Hereditary hemorrhagic telangiectasia, Osler disease, rare disorder with autosomal dominant inheritance. Dilatation of capillaries and small arterioles produce characteristic small red spots with that blanch and pressure in the skin and mucous membranes, particularly nose, gastrointestinal tract. Recurrent epistaxis, nasal bleeding, chronic gastrointestinal bleedings are the major problem and may cause chronic iron deficiency anemia. So the idea of this disease is very simple. In some part of his body, patient has some weak vessels. And these vessels periodically ruptured and cause bleeding without even trauma, without damage. And in some cases, it's in nose. In this case, patient periodically experience nasal bleeding. No, maybe it's not so dangerous. But if the same happened in gastrointestinal tract, in stomach, for example, patient periodically experience GI bleeding. It may cause even actually iron deficiency anemia, but rarely this bleeding becomes very severe because we talk about damage of small vessels. Easy bruising syndrome. It's very interesting syndrome. This is a common benign disorder occurring in otherwise healthy women. Usually it's happened only in women, characterized by bruises on arms, legs, trunk with minor trauma, possibly due to skin vessels fragility. It may give rise to suspicious of serious bleeding disorders. This is just constitution. For some reason, some women easily produce blue and black marks. Even small trauma, we have bruising, blue and black marks. But if you check and everything, you can't find actually a real bleeding disorder. No, we tell, okay, this is easy bruising syndrome. Don't worry, this is your body constructed this way. Senile purpura. No, actually, senile purpura due to steroids, due to atrophy of vascular supporting tissues. As a result, vessels becomes fragile and may produce small bleeding into the skin usually. Rarely it's caused severe loss of blood. Purpura due to infections, caused by damage to the vascular endothelium. For example, rash of meningococcal septicemia, particularly characteristic. So again, remember, severe headache plus some rashes like petechial red spots on the skin. Be careful, it may be meningitis. Without treatment, patient may die. Because meningitis, this is damage of brain. If you prescribe antibiotics, patient may recover completely. Next, Henoch-Schönlein purpura. Henoch-Schönlein, or in Russian language, in Russian textbooks, Schönlein-Henoch purpura, occurs mainly in children. It's a hypersensitivity reaction that is often preceded by an acute upper respiratory tract infection. Purpura is mainly seen on the legs and buttocks. Also, abdominal pain, arthritis, hematuria, glomerular nephritis also occur. No recovery is usually spontaneous, but some patients develop renal failure. So what we're talking about? This is vasculitis. Vasculitis. What does it mean, vasculitis? This is actually vascular disease, damage of vessels. What caused this damage? Usually this is autoimmune allergic mechanism. Infection cause production of antibodies, production of circulating immune complexes, which try to find and kill bacteria. But for some reasons, the same immune complexes, they may attack vessels because they're circulating in blood. If they attack vessels, it causes vasculitis, it causes inflammation of vessels, and we can see what? It's not real bleeding. It's usually what affected? Skin affected. On the skin, you can find specific rashes, vasculitic rashes, because they become palpable, because it's edema of small vessels. Some rashes on the skin. And if the same happened in gastrointestinal system, for example, in intestine, it causes clinical picture of acute abdomen, because it may be actual inflammation of vessels of intestine. That's why it may produce severe pain in abdomen. Sometimes even surgeons try to find out what have happened. If the same happened in kidneys, we just imagine inflammation of kidneys. You know what is inflammation of vessels in kidneys? It's known as glomerular nephritis. That's why we may say all signs of glomerular nephritis in case of this Schönlein-Henoch or Henoch-Schönlein purpura. No, this is usually benign, but in some cases it may cause damage of kidneys with development of renal failure. Next, platelet disorders. Bleeding due to thrombocytopenia or abnormal platelet function characterized by purpura and bleeding from mucous membranes. Bleeding is uncommon with platelet counts above 50, 10 times 9, and severe spontaneous bleeding is unusual with platelet counts above 20, 10 times 9. No, this idea of this disease is very simple. If we have low platelet count, no primary stop of bleeding, as a result, patient may expect bleedings in small trauma, even actually without visible trauma. Because, you know, whatever you do, small trauma happens all the time. But normally platelets completely block this immediately. But if platelet count is low, no blockage, as a result, patient experience some kinds of bleedings. Now you see again, usually all these bleedings, normal range of platelets, you see 100, 500. If from 100 to 50, no moderate hemorrhage after injury. 50, 20, purpura may occur hemorrhage after injury. If less than 20, no spontaneous hemorrhage from mucosal membranes, no rare intracranial hemorrhage. But you know, I may give you some examples. I remember patients with thrombocyte count 1 instead of 500, only 1, 10 times 9. And I remember no severe bleeding. Why? It's difficult to explain, actually. Human body is some miracle, and sometimes it's very difficult to explain what happened and why happened. So, causes of thrombocytopenia. Again, a lot of possible causes of thrombocytopenia. Now, for example, for all damages of bone marrow, for example, tumor, leukosis, which cause killing of megakaryocytes, which normally produce thrombocytes in bone marrow. What else may be? Immune. This is most important. Autoimmune damage of thrombocytes. No, sometimes hypersplenism, because you know what for we need spleen? Spleen we need to remove bad cells, bad blood cells, including erythrocytes, thrombocytes. When spleen for some reason becomes very big, for example, in case of portal hypertension in liver disorders, big liver remove more cells, and that's why it may lead to actually thrombocytopenia. The most common reason for platelets problems, this is autoimmune, idiopathic thrombocytopenic purpura, AITP, autoimmune idiopathic thrombocytopenic purpura. No, autoimmune clear, idiopathic without reason, we don't know reason, unknown reason. Thrombocytopenic, low count of thrombocytes, purpura, this is bleeding. Thrombocytopenia is due to immune destruction of platelets. Immune destruction of platelets. We don't know why, but our immune system produces antibodies against platelets. No result, killing of platelets, destruction of platelets. The result, no patient experience lack of platelets. Two distinct clinical syndromes in case of AITP. Acute AITP usually seen in children, often following viral infections, and acute development of platelet autoantibodies probably responsible for the shortened platelet survival. So in children, usually this disease lasts for a few weeks and disappear completely and without any consequences. In case of chronic AITP, usually it's seen in adult women. It's usually idiopathic, so no reason, but may occur in association with other autoimmune disorders such as thyroid disease, autoimmune hemolytic anemia, after infections with viruses such as HIV. Platelet autoantibodies detected in about 60–70% of patients, presumed to be present, although not detectable in the remaining patients. Clinical features. Major hemorrhage is rare and is seen only in patients with severe thrombocytopenia. What we have? Easy bruising, purpura, bleeding into the skin, the epistaxis. Epistaxis again, this is nasal bleeding. Menorrhagia, this is in women's long and massive menses. No physical examination normal except for evidence of bleeding. Splenomegaly is rare. How we can detect? Only blood count abnormalities, thrombocytopenia, so we find low platelets count. Normal increased number of megakaryocytes found in bone marrow, which is otherwise normal. No detection of platelet antibodies is not essential for confirmation of the diagnosis, which often depends on exclusion of other causes of excessive destruction of platelets. Okay, next, coagulation disorders. Coagulation disorders may be inherited and acquired. The inherited disorders are uncommon and usually involve deficiency of one factor only. The acquired disorders occur more frequently and almost always involve several coagulation factors. So inherited coagulation disorders, deficiencies of all factors have been described. So if you have factor, this factor may be absent due to some genetic problems. Those leading to abnormal bleeding are rare apart from hemophilia. So the most common inherited coagulation disorder, this is hemophilia. Hemophilia A, this is 8-factor deficiency, B, 9-factor deficiency, Willebrand disease. So hemophilia A, the level of factor 8 reduced, but the level of factor Willebrand is normal. The prevalence of hemophilia A is about 1 in 5,000 of male population. It's inherited as an X-linked disorder. If a female carrier has a son, he has 50% chance of having hemophilia. Daughter has 50% chance of being carried. All daughters of people with hemophilia, carriers and sons are normal. So I hope you studied biology. And in biology, they like to give example of hemophilia as genetic disease. Because again, it's X-linked disease. Or because the gene which produced this 8-factor placed in actually X chromosome. And why almost only men suffer from this disease? Because women, they have 2 X chromosomes. And if one X chromosome fails, second X chromosome have the same gene and no problems with production of this coagulation factor. In men, they have XY. And if they have a problem with one X chromosome, nothing can actually prevent or protect against low production of 8-factor. And without low production of 8-factor, no normal coagulation. Patient experience hemophilia. So, clinical features depend on the level of factor 8. If levels less than 1% of normal, no, it's associated with frequent spontaneous bleeding from early life. Hemarthrosis, bleeding into joints, common, and may lead to joint deformity and creeping if adequate treatment is not given. That's why many patients with hemophilia, they use sticks, they have problems with their joints. They can't walk normally. Bleeding into muscles also common. Intramuscular injection should be avoided because all even small damage or pressure or damage may cause very severe bleeding. Even tooth extraction may be potentially lethal for such patients. If you extract teeth, bleeding never stops. Bleeding or through small wounds, all bleed may come out. That's why extremely dangerous disease in such rate of absence of coagulation factor. Levels from 5 to 5 associated with severe bleeding following injury and occasional apparently spontaneous episodes. And levels above 5% produce mild disease, usually with bleeding only after injury or surgery. It should be noted that patients with mild hemophilia can still bleed badly once hemostasis has failed. Diagnosis in this group is often delayed until quite late in life. So now, you know, patients with hemophilia may be treated. How we can treat patients with hemophilia? We give them substitutional therapy. So we can give them coagulation factor, we can take from healthy persons. We can take blood from healthy persons, then we can get plasma, and then we can even separate definitely coagulation factor 8, and we have specific remedy, coagulation factor 8, and we can give transfusion of this coagulation factor to patients with hemophilia to prevent bleeding. So now this patient may live more or less normal life. So final slide. This is difference in actually tests depending on which disease. For example, hemophilia. Bleeding time normal. Remember what I told you. Bleeding time depends on platelets, on thrombocytes. And that's why if you make a small wound, first bleeding stop. But then bleeding may start again and never stop. That's why bleeding time is normal. Prothrombin time normal. Because again, I told you, when we give thromboplastin, we already substitute patients formation of patients thromboplastin, and prothrombin time is normal in patients with hemophilia. Vice versa. Okay, no, in other disorders, for example, in case of vascular disease, vasculitis, bleeding time may be increased, but coagulation time is normal. No, it's actually depends on which disease exactly happened. Okay, if you have questions, please write these questions in the chat, type questions in the chat. If everything clear, just write that everything clear, so we should be sure that you understand everything. Waiting for your questions or waiting for your reply. Again, guys, write your names, not in the chat. Write your names in the wall of contact. Да? We'll check the wall of contact to find out that you are present. In this chat, write only your questions or write that everything is clear. Everything is clear. Okay, guys, if no questions, in this case, we finish our lecture.